Hey, so thank you very much. I'm just going to get right into it. So I was asked to give you a mile-wide and inch-deep overview of what's happened in psychedelic clinical medicine trials over the past year, as well as give you a sense of what's coming. Um, let's see here. And it actually turns out there's quite a lot, if you were not aware. I'm going to talk about MDMA for PTSD, psilocybin for depression, psilocybin for pretty much everything else. The so-called rapid-acting psychedelics, I put this in scare quotes, and then I'll talk a bit about some other stuff as well. But suffice it to say, there are still we are in a very different place than we were 5 years ago, but there are many, many open questions when it comes to what we still don't know about psychedelics. Do they work? For which conditions? Who should not be administered psychedelics? If you get a favorable response and then it wears off, what do you do? Do you redose? Safety, there's still many open questions about not only safety under optimal conditions with ethical practitioners, but especially once this gets out into the wild. Can the trip be shorter? Does the trip actually matter? These are still questions that are not fully addressed. So let's jump into MDMA for PTSD. I'm just going to give you kind of a quick bird's eye view of what's going on there. So there are 2 phase 3 trials that have been submitted to the FDA as a new drug application. We will hear what the FDA thinks is a safe and effective drug in August sometime. There are, believe it or not, betting markets for everything, and you can bet on this still, I think. There's a betting market for whether or not MDMA will be approved, and it's 62% as of like last week. So make of that what you will. So the first phase 3 trial, this was not in the past year, but it's relevant. This is all people that had severe PTSD. They were given 3 doses of MDMA in highly psychotherapeutically supported conditions. These people were real patients. They were ill. They've had PTSD for a long time. And most had had prior suicidal ideation. Most had had prior treatment. Just trying to hammer that these are people that are actually quite impaired in many ways. And there's results. You have MDMA in red, placebo in blue, after session 1, 2, and 3. And one of the things I'll point out here is that, yes, this appeared to work, and in fact, quite well. You don't actually see a ton of separation, a ton of benefit over placebo after 1 session, and there's a cumulative effect with multiple doses. And again, first phase 3 trial of MDMA for PTSD, I'm just showing you this in a different way. If you look at remission with MDMA in red, you can see that there is, again, this cumulative effect. More doses appears to lead to more benefit, and you have about 30% remission versus about 5% for placebo. I'll skip over these. And again, bird's eye view, very quick. The second phase 3 trial of MDMA is very similar in design, but they also allowed people in with moderate PTSD, so less severe. And this is after 3 sessions. You have remission 46% in MDMA, and versus 20%. So again, it worked. This trial, there was better effect, but these patients were also likely less severely impaired. And this is just a summary slide from Psychedelic Alpha. I'll again point out, you see a cumulative effect of multiple doses. With 1 dose, you don't see a ton of separation. So we will know in August what the FDA thinks, so stay tuned about MDMA for PTSD. The next big thing, though, is, in terms of what's happened in the last year and what's coming, is psilocybin for depression. So there are 2 main players, Compass and Usona, that have ongoing phase 3 trials. So we're quite far along in drug development here. I'll quickly recap the phase 2 trials. So Compass, and this is, I think, still the largest psychedelic trial that's ever been published. They took people with treatment-resistant depression. They've been depressed. They had treatments that didn't work. Gave them 25 milligrams, which is a high dose, 1 milligrams, which is nothing really, placebo, and 10 milligrams, which is sort of enough to experience something, but unclear if it's enough to really experience much therapeutic effects. And just sort of to look at this in plain English, at the high dose group, they had about 30% remission, lower dose groups about 10. So this worked. This was not by any stretch a miracle drug, but it appeared to be effective in this population. And again, we're talking about the phase 2 trials. There was concerningly 3 instances of suicidal behavior in the high dose group, not in the lower dose groups. This is something that we're going to just have to watch and see as larger trials come out. And then the phase 2 trial, different group now, we're talking about Usona. This is psilocybin for depression, not treatment resistant. They single dose study, and again, pretty similar, lots of psychological support before, during, and after, and psilocybin compared to a vitamin basically appeared to be effective out to 6 weeks. This is just showing you that the remission rates were higher for psilocybin. So this is all a favorable safety profile. So that's just the groundwork leading into now we have multiple phase 3 trials of psilocybin for depression. And I believe these are now all enrolling. So Compass has 2. One is 005, so single dose of psilocybin versus placebo. And the other trial is using 3 dose range, 25, 10, and 1. And this is nice because you get to, everybody gets psilocybin. You get to see if is there an effect of a higher dose. It may be better for blinding. But rather than a single dose, they're giving 2 doses, which this is a very basic question we still don't know. Is multiple doses better than 1 dose? We actually do not really know that. Most psilocybin studies, unlike MDMA, are single dose studies right now. And interestingly, though, they also have this 1-year follow-up period where top part you can see the first trial, single dose. Bottom part you can see the second trial, which is 2 doses. So that's part A, the main part of the study, but both have a part B where people can be retreated. And I'm not actually sure what the criteria are there. And then a part C where people can be retreated open label, unblinded fashion if they relapse. And this will go on for a year, so this will hopefully give us a really nuts and bolts, real world idea about, are multiple doses better? What do you do if somebody relapses? Can you retreat them? These are just very simple questions that we don't really know yet. Usona, this is the other phase 3 trial, and they're doing single high dose, 25 milligrams, low dose, 5 milligrams, or placebo, and they also will have a 1-year follow-up period where if people relapse or they are just depressed, they may get redosed. So stay tuned. We're going to know a lot more about psilocybin for depression. And this deserves a special mention. So pretty much every single antidepressant intervention known to humankind can provoke mania or mood instability in people that have bipolar disorder. People that have bipolar disorder are often depressed, and they are excluded from psilocybin trials for the most part. This is a trial out of Shepherd Pratt, just 15 people, dosed folks with bipolar depression, and most importantly, it appeared to be safe, and nobody developed mania. So as we sort of expand the pool into more and more people with things like bipolar disorder, or more of a real world, riskier groups, it's good to see some safety data. Okay, so that's my just extremely brief recap about psilocybin for depression. Psilocybin, unlike MDMA, is being studied for pretty much everything now, including non-psychiatric indications. So the substance use disorders, in terms of recent and ongoing trials, you're seeing pretty much everything under the sun. I'm going to talk about this tobacco trial, which is now completed at Hopkins. I can't show you the latest data on it, and I'll show you old data on about 60 people, which has already been presented. This is quite possibly my favorite trial in psychedelics. So people get, and I was not involved with this, people get a month of CBT for smoking cessation. They are randomized to either get a high dose of psilocybin or nicotine patch, something that is approved, it works, it doesn't work super well. And both groups get lots of psychological support. Treatment is done, follow them up at 3, 6, and 12 months. And so let me just orient you here. The y-axis is % of people that are abstinent from tobacco. The x-axis is various time points in follow-up, months after the intervention is done. And on the left, you see bupropion, which is just an FDA-approved treatment for smoking cessation. This is the drug that works versus placebo. On the right, you see nicotine patch versus placebo. Again, a drug that works. And you see that neither of them are really beating 40% abstinence in long-term follow-up. And then psilocybin, and again, this is on about 60 people. The nicotine patch group, you'll notice, does about as well as nicotine patch should do, and in fact, a little bit better if you look at the time points. And then psilocybin is just doing quite a lot better, and doesn't seem to be, it's quite stable. This is an unblinded study, but I think is very believable. And there's also now a NIDA-funded multi-site study of psilocybin for smoking cessation at NYU, Baltimore, and University of Alabama, Birmingham. And speaking of University of Alabama, Birmingham, I think this is run by Peter Hendricks, I think has completed the study of psilocybin for cocaine use disorder. He presented this at APA and I missed it. I don't know what happened, I can't tell you, but it's one thing that's very interesting about the study is that this is a different population. These are, I believe, predominantly black, very Christian, mostly people who are not psychedelic enthusiasts and in fact perhaps a bit afraid. And so we need to just continue to study different populations. Again, can't tell you what the results are. It's not published yet, and I missed the talk. I'm sorry, but stay tuned. And then I'm running a trial of psilocybin for opioid use disorder. We've enrolled our first person. And there are also randomized trials for alcohol and methamphetamine. I can't, unfortunately, get into all these details of time, but none of these are published yet. Other than, yeah, actually none of these are published yet. These are mostly ongoing. Okay, palliative care. So this is like one of the original use cases of psychedelic therapy, and it kind of makes sense. Like people are transitioning, there's an existential component to it. There are now, you're gonna hear, I think, Yvonne and, sorry, I don't remember who, you're gonna hear about some of these trials today. I think it's worth noting that the Hopkins and the NYU psilocybin cancer trials are often talked about as being psilocybin for end of life, psilocybin for existential distress. But many people in these trials were not actively dying. Most people actually had, I think, a life expectancy more than 2 years. We're now seeing trials that are actually led by palliative care doctors. They're in hospice patients. So I'm extremely excited to see. Previous trials would sort of try to shoehorn psychological distress in people that have cancer into like a psychiatric DSM diagnosis. They're depressed, they have an anxiety disorder, et cetera. So this PATH trial at Dana-Farber, which I think we're gonna hear about today, is looking at people that are actually in hospice. It's looking at the outcome of demoralization. So it's not necessarily a DSM psychiatric diagnosis, but it's one that perhaps fits the situation better. And there's also a large multi-site trial happening across the country of psilocybin in palliative care. It's testing high dose of psilocybin versus ketamine. And I should also just harp, and maybe this is worth just repeating ad nauseum, all of these trials are administering psilocybin in the context of lots of psychological support. And so you shouldn't necessarily just think of this as the drug. Okay, we are also going to be running a trial of psilocybin for ALS at Hopkins. So lots is going to be coming in the palliative sphere. And psilocybin is also being studied for all sorts of miscellaneous conditions. There are 3 anorexia trials that have been completed. Only one has been published, to my knowledge, or only one has been published. And I think we're going to start to see indications for which psilocybin does not work that well or doesn't work so good or needs to be modified. There's not much I can say about the UCSD study. It was a single dose, 10 people. Mostly they actually had normal BMI on average, so they included people with partial remission. It appeared to be safe, and there were some subjective benefits, but weight didn't change. The Hopkins study, I don't know if I'm at liberty to say anything about that. And there's an Imperial study as well that's completed, which has not been published. PTSD, do I have a slide? Yeah. So there's nothing is published yet. But there are now several studies of psilocybin for PTSD that are ongoing. Compass, 2 days ago, I think, just did a press release that had it's a single dose of psilocybin, folks with PTSD. I think at 12 weeks, it was like 55% remission from a single dose. That's a small open label trial, but that's very good. And I think relatively favorable safety profile. Again, it's a press release. We'll see what happens in the publication, but this is quite encouraging. And there's multiple other trials going on. There's one at Ohio State, and these are all kind of smallish, open-label trials. They're not controlled, not blinded. I'm running a trial at Hopkins. It's going to start soon. We're going to add adjunctive psychotherapy. People will be randomized to treatment as usual with psilocybin or cognitive processing therapy plus prolonged exposure. And there's another trial in Toronto that will add formal psychotherapy before psilocybin. So unfortunately, not a ton to say about this other than there are trials happening, and these are going to be, we're going to know a lot more about this soon. Oh, sorry. And yes, this trial had 2 instances of suicidal ideation, the Compass trial, that were deemed related or possibly related, and they resolved. So we'll learn more about that, I'm sure. But this is, again, you can't really compare this to the MDMA studies. It's possibly a different population. There's no real comparator, but this is extremely good for a single dose, and honestly, I'm surprised. Okay, so there's all kinds of other stuff that's happening. The basic point I'm just going to make here is that other than MDMA and psilocybin, there's now multiple other drugs that are being studied. There's interest. Psilocybin takes a whole day to administer. There's interest in studying shorter acting drugs. I have this term rapid acting in scare quotes. So 5-MeO-DMT, DMT, these are often called rapid acting drugs. There's nothing intrinsic to the drug itself. If you injected somebody with psilocybin, it will also be short acting. But nonetheless, there is interest in seeing, can we get comparable therapeutic effects without spending the whole day? We don't really know yet, but there are some trials I'll touch on. There's also LSD is being studied again, so it's kind of going in the opposite direction, a longer experience for generalized anxiety disorder. And there was a press release on that. It appeared to work for generalized anxiety disorder. And then phenethylamines, this is like mescaline-like drugs. It pains me that nobody is, I don't know that anyone's really studying these as therapeutics yet. And I'm honestly not entirely sure why. These are drugs that kind of have some MDMA type effects. It's plausible that they may be more beneficial for some populations. But I think it just still speaks to our infancy, and a pretty major class of psychedelics is still not really being investigated much. And we also have MDMA analogs that are, I believe, now in early human studies. I'm not really talking about ibogaine, but there are some situations where I'm quite hopeful that our chemist colleagues can help us out. And that's, for example, designing a non-cardiotoxic ibogaine. That would make it a lot more plausible, I think, for making it a real treatment. That's, I believe, in early studies in humans. And then there's what I jokingly call non-psychedelic psychedelics. There is, I suppose, a camp that believes that you could get lots of psychedelic therapeutic effects without the psychoactive, subjective, the trip. I find that implausible, but it's really nice because you can just test that. And it's quite possible that you could design a drug that strips away lots of the psychoactive effects, but still produces some degree of therapeutic benefit. So people have designed these drugs, and they're now giving them to humans, and we can see what happens. Again, I'm using the scare quotes here. You can make psilocybin rapid-acting if you administer it differently. And I have some slides about study. Let me just convey the point that DMT, injected DMT, and 5-MeO DMT, intranasal, have been given to people with depression. These are small studies that basically show, look, it appears to be safe, and there is some signal that maybe it's actually helping people with their depression, and it's happening pretty quickly. That's about all we know right now, and there are bigger trials that are now underway. This is a trial of DMT, and honestly, the slide is a bit confusing, so ignore it. But it's not my fault, it's their slide. But they administered IV DMT or a placebo, and then it's basically just showing you that it's kind of a fairly modest improvement in depression. After that dotted line, everyone gets DMT, so you should not really look past that. But this was, I think, small pharma. Now they were bought by Cybin or something. This is not published. This is a press release. But, oh, yeah, there we go, sorry. So DMT, very, very early studies, some evidence that it's safe, maybe will be helpful for depression. This will be good for us to really get a good sense of, because this is a very short-acting treatment. And 5-MeO DMT, there are two kind of main players I'm aware of that are doing trials. GH, this is published. And again, just don't take too much away from this. We're talking about very small trials that are showing like it's safe and there's some initial signal for maybe it works. You really have to wait for bigger trials. But they had a study of 16 people, treatment-resistant depression. It was well-tolerated, rapid effects a day later, a week later, and an individualized dosing regimen. Not just here's your dose, but kind of a graded approach appeared to be more effective. They have a study of 80 people that they're currently recruiting for. And then Beckley, this was a press release, it was not published, all the usual caveats apply. Small study, treatment-resistant depression. And again, appeared to be safe. There was pretty good results, but they have a larger study that's currently recruiting, so stay tuned for that. And you know, this is my job. I work in psychedelic clinical trials, and I am learning as I talk to people today that there were trials I was unaware of. I think I accidentally skipped over. There's other things that are like psilocybin's being studied for OCD at Yale, at Hopkins. I was entirely unaware that University of Arizona is also launching, I think, some fairly large trials. There are now many, many chronic pain studies that are emerging that I think are probably too numerous for me to enumerate. And I've not even touched on the non-psychiatric indications that are being studied, like psilocybin for headaches, psilocybin for post-stroke motor recovery. So I'm going to wind down here. We are an unusual branch of science in that there's not a lot of government funding. There's now government funding, and I'm sure that there are some that I've missed here, but the floodgates are not yet open, but we are seeing meaningful government funding of clinical trials. And this is only America. Canada is also funding studies. The EU is also funding studies. So I pray and hope that this kind of continues. And I'll wind down here. We are learning a lot. We may have an approved drug. There's a lot we still don't know. This is frankly just a laundry list of studies that I would like to do, but it gives you a sense of there's so much low-hanging fruit still. Once MDMA, if it's approved, there's endless questions about real-world implementation. Psychedelics in general, there's lots of questions about optimizing psychological support. Rapid-acting psilocybin, can you get similar therapeutic effects? We're going to be running a trial combining psilocybin with MDMA along with Sinai. I'm not gonna subject you to all of these. You can see, but I do think that combining psychedelic therapy in the context of existing treatment is also a pretty untapped, very valuable, fruitful avenue. I'll stop there. I don't know, is there question time? Or you can just use the time if we're running behind. Okay, I'll stop. Thank you.